Hello, my name is Justin, and I would like to welcome you to today's event titled Post-Surgical Pain Management Techniques for Enhanced Recovery, hosted by the Foundation for Women's Cancer. The Foundation gratefully acknowledges Pacira Pharmaceuticals Incorporated for providing an unrestricted educational grant in support of this webinar. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. To ensure that you can view all content within this event, please make sure that your event window is maximized. At any time, you may adjust your audio using the volume slider bar located in the upper left of your event window. If necessary, please also adjust any computer volume settings that you may have. Regarding Q&A, please submit your questions at any time by using the Ask a Question feature. On the left-hand side of your screen, you will see the Ask a Question window. Please ensure that the window is active by clicking on the gray bar until you see a white text box with a Send button. To send a question, click in the text box and type your text. When finished, click the Send button. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. All questions that you submit will be seen only by today's presenters. Please send a sample message now with your connection location. At the conclusion of today's program, we ask that you complete a brief post-event survey. Please take a moment to complete this survey, as it will help the Foundation for Women's Cancer plan future web events. Regarding technical support, we will monitor text chat for any issues that you report. Our help desk is also available throughout this event by calling 1-866-853-2566. Please reference code 00579 when calling. This number is also located at the bottom of the event window. For a telephone audience, you may press *0 for the teleconference operator to report any audio problems. At this time, I would like to introduce our speakers. Sean C. Dowdy, MD, Professor of Obstetrics Gynecology, Deputy Director of Practice, Robert D. and Patricia E. Kern Center for the Science of Healthcare Delivery, Mayo Clinic College of Medicine, and Pedro T. Ramirez, MD, Professor, Director of Minimally Invasive Surgical Research and Education, Department of Gynecologic Oncology and Reproductive Medicine, the University of Texas MD Anderson Cancer Center, Houston, Texas. I will now turn the microphone over to our first presenter, Dr. Sean Dowdy.
Thank you very much. My name is Sean Dowdy, and I'm happy to have the opportunity to participate in this webinar on pain management after gynecologic surgery, which is a very important topic. I have no disclosures today. So first I want to talk about pain management more in the larger context of a perioperative care pathway called enhanced recovery. Since many of the things that can impact pain, we can't limit pain control to the treatment of pain only. So there's also a preventive component to that, and enhanced recovery in some ways addresses prevention of pain. So about 5 years ago, in 2011, our team sort of reevaluated our clinical practice of how we manage patients after surgery. And some of these untested practices of perioperative care that I'll talk about in just a minute were abandoned in favor of alternative management strategies. And the primary goal of all these changes was to hasten patient recovery. So about 100 years ago, William Mayo once said that the best interest of the patient is the only interest to be considered. And in the spirit of that, we've worked diligently to diffuse what we've learned to other hospitals, so not just our patients, but all patients can benefit from these improvements with enhanced recovery, not only with recovery, but with pain control. And that's part of the reason I'm speaking to you today. So some of these untested perioperative practices that I mentioned before include the following. It includes things like mechanical bowel prep. Probably many of you are very familiar with the golightly bowel prep that you have before surgery or with colonoscopy. We've, in the past, not used a lot of regional anesthesia like local blocks. We've used a lot of narcotics, oral narcotics. Also prolonged NG or nasogastric suction. That's the tube that many of you have perhaps experienced that goes through your nose and your stomach that drains secretions. We have prolonged urinary drainage, the Foley catheter. We use a lot of patient-controlled anesthesia. That's the button that you can press that delivers IV narcotics. And the other thing is that in the past, we've traditionally not given any patients any food or drink after midnight the day before surgery. We use a lot of drains, give a great deal of fluids during the procedure, and also don't feed patients after the procedure, and also limit them to a great deal of bed rest after surgery. And what all these practices have in common is that they're not particularly pleasant for the patient. And our reasoning was that if it brings unnecessary discomfort to patients and we don't have any real benefit from it, then these are things that we should discontinue. So this shows some of the sort of untoward effects of those untested perioperative practices that I just reviewed. This includes things like fluid overload, nausea and vomiting. It can increase the risk of infection, leads to a lot of patient dissatisfaction, dehydration, can also increase pain, and patients can also have difficulty sleeping with all these interventions. So enhanced recovery was really a transformational change. Dr. Ramirez will talk about this in a little more detail, but just suffice it to say that this has really been a transformational change, not only in our post-operative recovery, but also the preoperative and the intraoperative management. This is the project team we used about 5 years ago, and the names aren't as important as just the fact that we have many stakeholders that were involved in this process. So this wasn't only physicians, it was also administrators. We had a project manager. We involved the anesthesiology consultants, the residents and fellows. We had representatives from pharmacy operations, and nursing made up about half of the team as well. So it was very important that we get input and perspective from all these different sources when we made these changes to our perioperative care pathways. So again, I won't go into the details of enhanced recovery, but I want to highlight three specific elements that are really important, sort of the three main tenets of enhanced recovery. And the first one is euvolemia. And many of you will remember that old story about Goldilocks and the Three Bears and how there was porridge that was too hot and too cold, and there was one bowl of porridge that was just right. And that's what we want to do with the fluid management during surgery. So we don't want too much fluid, that's hypervolemia. And the problem with too much fluid is you can get a lot of swelling in your face and your hands. Those of you who experienced surgery may have potentially experienced that in the past. And the problem is you have that same sort of swelling on the inside as well. So all that swelling you see in your face and your hands, you also have around the bowel, and that can lead to increased pain. And it can also lead to reduced recovery of your small bowel as well, and you can potentially have difficulty eating. And then if we don't give you enough fluid, you can potentially have difficulty with renal toxicity, with kidney failure and things like that. So again, we don't want too much fluids. We don't want less than enough fluids. We want just the right amount of fluids, and that's euvolemia. The second main tenet is early feeding, and we know that great nutrition leads to great healing, and great healing leads to great outcomes. So we want to optimize the nutrition before surgery. We also want to optimize the nutrition after surgery, and that does not include withholding calories for several days after surgery. So patients will eat, in some cases, the evening of surgery. That's sort of our standard. And then the third tenet is pain control, which I'll talk about in just a minute. So, one of the things that we do with early feeding is we give carbohydrates the night before surgery, again, to sort of deliver the optimal nutritional status before we put a lot of stress on the patients. And that may sound familiar. That's very similar to what we do before athletic performances to improve our results. This is a photograph of my wife and my daughter after we did a half marathon, and it's very similar preparation for surgery as you prepare for a race. So we make sure before a race you make sure that you're well nourished. You give carbohydrates the night before. You make sure we're well hydrated. So you certainly don't want to be dehydrated before a race. You don't want to be overhydrated either. And we make sure we're well rested. And one of the other things we do to optimize fluid management is we stop using bowel preps. And certainly you wouldn't think about using a bowel prep before a half marathon. So all those sort of logical steps that we do to optimize our recovery or our performance during athletic performance, we use for surgery as well. So then the third part is, of course, pain management, which is the subject of this webinar. And easing suffering is obviously one of the main goals of being a physician, and something that's very important in the postoperative recovery period. So we'll just review some of the options for pain control after surgery. And the first one is something called intrathecal analgesia. and many of you will recognize that as spinals or the use of epidurals. Probably many of you have experienced this in labor if you've been pregnant in the past. And the advantages of this is that it's potentially extremely effective. So I would consider epidurals sort of the gold standard of pain control. There's also some evidence that improves bowel recovery. So those are two of the reasons why in the past we've used intrathecal analgesia and an enhanced recovery protocol. Certainly that's used a lot in colorectal surgery. But there's also some disadvantages as well. The first one is that the effectiveness varies between providers. So I'm guessing a lot of people on this webinar, if you had an epidural, if you were pregnant, many of you probably had an epidural that didn't work particularly well. So maybe it worked in one leg but not the other. Sometimes it doesn't work at all. So this is a potential disadvantage of epidurals. It can also cause low blood pressure, and if it causes low blood pressure, then we have to give the patients more fluids, and that interferes with that concept that I talked about earlier with euvolemia. Another thing is rarely patients can have difficulties with sedation and respiratory depression, so that's something we want to avoid. Patients can also have difficulty ambulating after surgery, and that's very important to get them back on their feet and recovering quickly. Epidurals are also time-consuming, and lastly, they're quite expensive. So if we look at the literature that's been published recently, in reality, the pain control that we get from epidurals in the context of gynecologic surgery is not really any better than we can do without epidurals. And also there's some evidence that the complications are higher when we use epidurals or spinal analgesia. So this is something that we don't currently use in our enhanced recovery protocol. We use it very rarely, probably in 1% to 2% of patients. It can be helpful in some patients who have used narcotics before surgery that we anticipate are going to have a lot of problems with pain control. But in addition, this isn't our standard of care. That doesn't mean it's wrong if you receive it, but it's not something that we think is absolutely necessary. So I'll talk about other ways of managing pain control, and probably one of the most important concepts to understand is this concept of synergy. So synergy is an interaction or cooperation of two or more agents that produces a combined effect that's greater than the sum of their separate effects. So we all know that 1 + 1 is 2, but there's something about some agents that when you use them together, 1 + 1 = 3 or more than 3. So this is something we also see in chemotherapy. Sometimes if we use two agents, the combined effect is better than if we used each of those alone. So a lot of the medications we use for pain control work better when they're used in combination. So our current approach to pain control starts before surgery. So this is important. So we call this preemptive analgesia. And so the three medications we currently use are celecoxib, gabapentin, and acetaminophen, which many of you will recognize as Tylenol. And that's given as an oral preparation before patients would go to sleep for surgery. And then the maintenance drugs that we use during surgery includes opioids or narcotics. We also use ketamine and ketorolac, which is a very strong IV version of ibuprofen. And then the last thing we use is wound infiltration with a local anesthetic. And all these different medications and techniques are work through different sort of mechanisms, but as I said earlier, they are synergistic when used together. So I want to talk a little bit more about bupivacaine. That's the local anesthetic that we inject into the wound after the operation. And we at first use something called bupivacaine, a regular bupivacaine, and then as a second phase of enhanced recovery, we introduced liposomal bupivacaine. And some of you may be familiar with Doxil, which is a liposomal preparation of adriamycin. Here we use a liposomal preparation of bupivacaine because it has a longer half-life. So the standard bupivacaine that we used before has a half-life of 6 to 8 hours, but with liposomal bupivacaine, this lasts 3 days, probably more like 2 days, but sometimes up to 3 days. So it's much more effective and lasts quite a bit longer than standard bupivacaine. Now, some people advocate for something called TAP blocks or Transversus Abdominis blocks, and this is something that is potentially quite effective. We contemplating using this with the liposomal bupivacaine in the past. The problem with it's somewhat time consuming. You have to use ultrasound to locate those nerves that you see on the figure there. The other problem is that we didn't think that the tap locks would be as effective as simply administering the drug directly into the surgical incision. And since then, actually, there's been some randomized trials that have compared tap locks to local injection, and they've shown that it's actually more effective if used directly into the locally into the incision. We're not completely sure what the reason for that is, but there's also some differences in the distribution of the nerves between patients. And you can also see that those nerves come from each side of the patient and meet in the middle, so there may not be good coverage right in the midline if you give the injection way off to the side. So again, just like the epidural analgesia, this isn't something that's wrong if the anesthesiologist chooses to use that, but it's not something that we currently use now, and we actually think it's a little better if you just inject the drug directly into the wound. So those are preoperative and intraoperative ways to control pain. The other thing to discuss is how we control pain postoperatively. And again, we use multimodal analgesia, getting back to that concept of synergy that I talked about earlier. So we continue to use ketorolac or ibuprofen after surgery, and then we supplement that with acetaminophen and oxycodone. And then if the patients continue to have pain despite those oral medications, then we give IV Dilaudid, which is a narcotic. And if they need more than 2 doses of that Dilaudid, only then do we start a PCA or a patient-controlled anesthetic. So some of you may be familiar with the PCA. That's when you have a button, and if you have pain, you push the button. The problem with that is we've seen that patients tend to really overtreat themselves. And so we don't want to undertreat patients, but we don't want to overtreat them with narcotics in the postoperative period either. So this kind of sums up the improvement that we've seen with our enhanced recovery protocol. Before 2011, using what we'll call conservative management, our length of stay was 8 days, and nearly 100% of patients use PCAs. And then when we migrated to enhanced recovery, our length of stay went down by 3 days. We had a significant reduction in the use of PCAs. And we also, which accompanied an 80% reduction in narcotics overall in the first 2 days. And with that, we saw greater than 90% patient satisfaction. And then when we added liposomal bupivacaine, we saw a further reduction in the need for PCAs. And so at this point, we have a 90% reduction in the use of narcotics in the first 48 hours. And we also saw some other improvements, like a reduction in ileus. That's when patients have difficulty eating postoperatively and get distended and have nausea and vomiting. And finally, we did a cost analysis to make sure that we weren't adding undue cost to the whole process, and this addition was found to be cost neutral. So I just want to talk about the opioid use a little bit more, because this is a really important thing to emphasize in the context of this webinar on pain management. So with conservative management, patients received an average of 351 milligrams of morphine. If we can convert all those different pain medications to morphine equivalents, it was the equivalent of 351 milligrams in the first 48 hours. And then when we went to enhanced recovery, that was reduced to 69 milligrams. And then when we added the liposomal bupivacaine, that decreased to 37.5 milligrams on average. So again, that's a 90% reduction in opioid requirements. And obviously, we wanted to look at pain scores as well, because if we reduced the amount of pain medications that patients were receiving, but they're having more pain, then we weren't helping much. So we wanted to make sure that the pain scores were stable, and we actually saw that the pain scores were unchanged and potentially even a little better with these changes that I've talked about. So I think one good question is, why do we care about how much opioids patients receive after surgery? And I think all of you know who this is. This is Prince, who unfortunately died earlier this year. He lived about an hour from where I am in Minnesota. And he was addicted to narcotics, and he died of an overdose. And this happened not because he was a drug user. In fact, he was a Jehovah's Witness, and he was very anti-drugs, which was unusual for a musician. It's not because he's black. It's not because he was a criminal or he had some sort of personal shortcoming. I think his death is sort of emblematic of the crisis that we have in this country with narcotic use and narcotic abuse. So I wanted to give you some facts about opioids. Over the last 10 years, we've seen a 400% increase in the sale of painkillers, including narcotics, and we've had a 900% increase in the need for treatment for narcotic dependence. And currently about 12 million Americans use prescription pain medications for non-medical purposes without a prescription. So one of the problems is that you can get narcotics over the internet without a prescription. And in fact, last year, the CDC added opioid overdose prevention to the top 5 public health challenges for 2015, recognizing what a problem this is. And a lot of us think of heroin as sort of this awful drug that sort of homeless people use, but the fact is that 80% of heroin users started their abuse with prescription painkillers. So physicians actually own a lot of the current abuse because we get patients hooked on narcotics, and that escalates. They need more and more narcotics, and eventually some of these people will even start using heroin. So this is something that patients need to be cognizant of and something that physicians need to be aware of as well. This graph shows opioid sales over the last 10 or 11, actually over the last 10 years since 1999. And you can see as the opioid sales increased, we also saw an increase in deaths attributable to opioids and also an increase in opioid treatment admissions. And again, all those effects can be directly related to prescriptions that are provided by physicians. This is some work that some colleagues of mine did from Mayo Clinic last year. We have a database called the Rochester Epidemiology Project that includes patients from the entire county of Olmsted. This is about 142,000 patients. And we found that in 2009 alone, 12% of patients received a prescription for opioids. So more than 1 out of 10 patients got a prescription for a painkiller. And of those who got a new prescription, 21% went to an episodic pattern of use of opioids and 6% to long-term use of opioids. And we also found that episodic and long-term use, but not short-term use, was associated with substance abuse. And this is a really important distinction. So it's certainly okay to use opioids in the short term after surgery, but we want to minimize the amount of opioids that you need after surgery, and we want to make sure that that's a short-term use and not a long-term use because that exposes you to additional risks. So I just want to end with a couple of take-home points. The first one is that the enhanced recovery pathways hasten surgical recovery and improve patient satisfaction. This is something that's used at more and more hospitals. We're working diligently to diffuse this practice across other hospitals in the United States, and I would really consider this standard of care at present. It's important to know that there's many techniques to reduce pain, but a multimodal approach is really the best way to approach pain. And although opioids are a critical element, it's important for you to know that they're not the only element of pain control. And lastly, opioid dependency is a major public health challenge, and we really need reform of opioid practices, and we really need to increase awareness of this. So finally, my goal each day is just to do a little better. We're certainly far from perfection in the medical care industry in the United States, but if we can just do a little bit better every day, we can get that much closer to perfection. So that brings me to the end of my presentation. At this point, I'd like to introduce Dr. Pedro Ramirez from MD Anderson Cancer Center. He and his group has done some great work with enhanced recovery after surgery. I've had the privilege to know him for many years. He's a fantastic surgeon, teacher, and researcher, and a great sense of humor, so very happy to introduce him today. And following his presentation, we'll have some time for questions. Thank you.
Great, thank you, Sean. And I want to thank the Foundation for Women's Cancer putting together this webinar. And certainly I want to thank the audience for being here and for showing your interest as I see questions coming in already. So for the remainder of the webinar, I wanted to share with everyone the program that we've developed here at MD Anderson and Gynecologic Oncology that we began in November of 2014. We began our enhanced recovery program as part of a quality improvement initiative rather than a research protocol. And since November 3rd of 2014, we have operated on 676 patients under the Enhanced Recovery Program. And I'll talk a little bit more about some of the details with regards to the data that we've gathered on those patients since we began the program. We began with a mission, and a mission statement for us in our department was to implement evidence-based practice and innovative research and to enhance recovery after surgery and improve patient-centered clinical, surgical, and oncologic outcomes. And as Sean mentioned, one of the key elements of developing any enhanced recovery program is to assure that you have a team of individuals who are all committed to the success of the program and the developing and further growth of the program. So for us, we had an agreement as a department under the leadership of Karen Liu that all faculty in GYN oncology were going to participate and initiate their practice as part of the enhanced recovery protocol. So we made a decision as a group that as of November the 3rd, 2014, all patients undergoing laparotomy at MD Anderson for any gynecologic surgery were to be on the enhanced recovery program. Anesthesia is obviously key, is a key element to the success of the program. We had a tremendous amount of effort put into the training of the nurses in the pre-op, intra-op, and the post-operative period, so everyone would be aware as to what would be the expectations for the program. Obviously, in addition to this amazing team, you have to have a team of individuals who are able to capture that data. We have an outstanding team of research data coordinators. And also we have the input from a statistician that helps us develop the database that we use. I'll talk a little bit more about that in a second. But this is a database that currently we hold the information on those 676 patients. Each patient has 787 fields, so certainly it's quite an endeavor for the team. The key elements, as Sean mentioned, are basically getting away from the patterns of practice that were used in old tradition, where it was, this very heterogeneous pattern of who uses bowel prep, who uses drains, when our patients started on their diets. So basically, the principles, as you see here, is the principle of no bowel prep, a set of pre-medications, and I'm going to go over the details of those. The use of nasogastric tubes is no longer part of our program. Removing the Foley catheter early. A series of opioid-sparing analgesia. Goal-directed fluid therapy. Normothermia. Using VTE prophylaxis as routinely indicated by guidelines. The postoperative multimodal analgesia regimen that I'll talk briefly about. And then also emphasizing early feeding and definitely early postoperative mobilization. This is an effort that we maintain through the regular meetings with our group. We have weekly team meetings for the Enhanced Recovery GYN group. All the data tracking is on the REDCap database, and I think this is a fantastic database for any of you who are beginning your program. So that you will be able to maintain all of the information that you're capturing on your patients. We also have a research steering committee that guides us with regards to what is going to be the relevant topic of research and investigation within this quality improvement program. And then also we have a yearly team retreat where we gather the information of the things that we feel are being done correctly, where we talk about what are some of the goals over the next several months or the next year, so that it gives us an opportunity to sort of audit ourselves with regards to the success of the program. I'm going to present a series of slides where basically gives you a representation of the parameters that we have changed preoperatively, intraoperatively, and postoperatively. These slides will show what our previous practice was and then now what is the enhanced recovery practice. As you see, as it pertains to diet, prior to beginning the enhanced recovery program, it was a standard nothing to eat after midnight until surgery. Under the new program, we still recommend no solids after midnight, but we allow for clear liquids up to 2 hours prior to surgery. The issue of carbohydrate loading, I think certainly Sean mentioned that this is routinely done in their institution. we're looking at exploring possibility of doing a prospective study evaluating the role of immunonutrition in patients prior to surgery. So as of now, we don't routinely use immunonutrition or carbohydrate loading prior to surgery, but certainly it's one of the areas that continues to be evaluated. As it pertains to bowel preps, prior to the implementation of the program, this was basically physician discretion, where some surgeons used it routinely, other surgeons used it sporadically, others did not at all. Based on the literature, and there's extensive literature both in GYN and in colorectal surgery, there is no evidence that by routinely using bowel preps, we decrease the rate of postoperative complications or the rate of postoperative leaks. You certainly decrease patient satisfaction, so therefore we do not use bowel preps even in the setting where we know that we're going to perform a bowel resection. As it pertains to the pre-medications, previously it was based on anesthesia discretion, but now we have a set standard orders that we use for our preoperative patients, and I'm going to show what those are briefly. And then lastly, IV fluid therapy. We try very hard to restrict the amount of fluid that a patient will get prior to entering the operating room. As you know, in many scenarios, the patients can already potentially be fluid overloaded prior to even making incision, and then obviously that has been shown to impact the outcome of patients postoperatively. So therefore, we have strict criteria that patients will have a HEP lock all the way up to the point where they go to the operating room, and then the IV fluids will start at that point. For those of you who are interested in the specific details of the medication regimens that we use, this is our medication regimen. As you see, is celecoxib, tramadol, pregabalin prior to surgery. IV acetaminophen is given at the anesthesia induction, and then anti-anxiolytics and anti-nausea medication is also given as per anesthesia. We routinely use heparin prior to our surgeries, and this is already written as part of a pre-operative order set. Now, intraoperatively, the antibiotics, there's no change in the standard prophylaxis ACOG guidelines that we use. As it pertains to anesthesia, we have tried to make a very strong effort to move towards what is called TIVA, or total intravenous anesthesia. And the reason for this is because it's been shown that total intravenous anesthesia may potentially certainly improve the outcomes of patients postoperatively as it pertains to not only pain management, but also as it pertains to patient-reported outcomes and quality of life for that patient. As Sean mentioned, epidurals, certainly when we look at the interventions that are made in most enhanced recovery programs, epidurals are encouraged. In our institution, we elected not to use epidurals. The reason for that is because we felt that in our setting, it certainly delayed patient recovery. There were the factors also, as Sean mentioned, when patients have episodes of hypotension, then usually the rebound reaction is to give fluids to that patient. So therefore, we elected not to use epidurals. We don't use them in our patients routinely. We do perform local wound infiltration, which we find has made a significant difference in terms of the postoperative pain management. And we are about to begin a randomized trial where patients are undergoing randomization to standard bupivacaine versus a combination of liposomal bupivacaine or Exparel with standard bupivacaine, and this is a trial that is supported also by PACIRA. In terms of intravenous fluid therapy, we use non-invasive cardiac monitoring to assure that the anesthesiologists have a much better control of the fluid that is given in the operating room in an aim to maintain the patients in what is called a euvolemic state. We don't routinely use nasogastric tubes, even when the patient has, I mentioned, even if the patient has had a small bowel resection, we don't routinely use nasogastric tubes, and we try to stay away from adding additional drains at the end of surgery. The Foley catheter before was removed at physician discretion. but now it's removed on postoperative day number 1. This is the medication regimen that is used intraoperatively by our anesthesiologist, and certainly this is available to anyone who has joined the webinar, and we'll have these available on your request. Then in the postoperative period, again, there's a significant emphasis on trying to not fluid overload patients. So our standard order sets calls for intravenous fluids at 40 cc's per hour. And as soon as the patient is tolerating a diet, anything by mouth, then it goes to a HEPLOC. In terms of analgesia, as I mentioned, we don't use epidurals or PCAs. We use an oral regimen of acetaminophen, ibuprofen, pregabalin, oxycodone, and if there has to be a rescue, then we use hydromorphone intravenously. The diet is also a big change for us. Before, obviously, it was very variable, and it was according to physician discretion. Now we feed patients the same day of surgery. So if a patient has had a bowel resection, that patient will still have a regular diet on the same day of surgery. Just 2 days ago, I had a patient who had a cytoreductive surgery with resection of the small bowel with reanastomosis and resection of the large bowel with reanastomosis, and she was given a regular diet on the day of surgery, and she so far is doing well. So this is something that we do emphasize. We are incorporating now the help of a dietitian and to our team. So a dietitian will see the patient preoperatively and then also consult on the patient postoperatively to make sure that they're getting the appropriate diet in the postoperative period. We do encourage patients to ambulate, so we ask them to ambulate at least 8 times per day. All meals are served in the chairs, no meals are served in the bed, and the patients are encouraged to be out of bed for 8 hours daily. And in addition to that, we have a restrictive policy on transfusions, and we typically don't transfuse patients unless their hemoglobin is less than 7. This is the regimen that I mentioned for the postoperative period, and as I said, this will be available to all who are interested in what the actual dosing that is given on the preset order set for the post-op patients. I certainly don't encourage anyone to actually look into all of the details of these slides right now, but this is basically a process map that we certainly encourage, and this is something that we find that it is key when beginning a program because it gives you an opportunity to know exactly along the path from the patient first coming into our clinic all the way to the patient going home as to what is expected of that patient and where are the checkpoints for that patient to move through as they go through the perioperative period. So as you can see here, each of these are areas where we have a strict criteria for making sure that the patient is not missed through the enhanced recovery process. This is for the day of surgery. As you see, we have the checklist for pre-op anesthesia assessment, for intra-op management, and then for post-op day 0. And then lastly, also the inpatient unit and all the elements that are anticipated and expected on post-operative day 1, day 2, and day 3, and subsequent hospital stay. Just with regards to what are the results and what have we seen, obviously, we have had several publications. This is one of the publications by Larissa Meyer that was published in Gynecologic Oncology, and basically looking at patient-reported outcomes through the use of the Medasi questionnaire that we developed here at Anderson. We also published in Gynecologic Oncology the guidelines for pre, intra, and postoperative management under an enhanced recovery program, and these are all published in Gynecologic Oncology. They were the most downloaded papers in the last 3 months, so we're very pleased to see that, and certainly encourage those of you who are interested to read the guidelines. We've also had an opportunity to explore and do research on the work that we've done. We presented at the World Enhanced Recovery After Surgery Congress Our team has looked at variable numbers of topics within the program. And as you see here, we've looked at models to predict postoperative complications. We looked at whether obese patients benefit from an enhanced recovery program. We looked at the impact of bowel surgery after an enhanced recovery program has been implemented, the approach on age and how that impacts elderly patients on enhanced recovery. We've also looked at preoperative order sets and how that impacts postoperative analgesia and DVT prophylaxis, the issue of how intraoperative opioid administration has decreased over the implementation of the program, and also is euvolemia ideal for all or for a select number of patients within our enhanced recovery program. So obviously it gives us an opportunity to also look and evaluate the impact of implementing this program. Just to give you an overview of what our typical patients are, generally this is for primary cancer. A number of patients are for recurrent disease, and then number of surgeries for benign disease, as you can see the details of the specifics on each of these patients. The majority of our patients are ovarian cancer patients, and certainly obviously because these are for tumor reductive surgery. And when we look at the implementations and the outcomes pre and post implementation, we have shortened the length of stay. There has been no impact on readmission rates, and that's very important because obviously we don't want to boast about how we are having patients recover much quicker and going home much quicker, but then having them get readmitted. So the readmission rate hasn't changed. Also, there has been no change in terms of GI, GU, neuro, or hematologic complications for implementing the program. And we're now evaluating something that is very important, which is called the RIOT, or Return to Intended Oncologic Therapy. Similar to what Sean was describing, we have seen an 80% reduction in opioid consumption in the postoperative period. As you can see here, this is a representation of pre-enhanced recovery and post-enhanced recovery as it pertains to morphine equivalents in patients that are operated under this program. 16% of our patients have no opioid use at all during the postoperative period. And in addition, as you see here, there has been no change in pain scores. So therefore, even though we have reduced the opioid consumption, the patients are doing very well as it pertains to reporting pain scores. The other element is patient-reported outcomes. Larissa Meyer has headed the program in this area, and we have a composite of very strict criteria under MEDASI to evaluate the patient-reported outcomes, and then we have seen a significant improvement in those outcomes as well. One of the things that we also are interested in is the cost analysis, and we did a preliminary evaluation of our team here, and we saw that with a decrease in the mean length of stay associated with the adoption of this program, this led to an estimated cost difference of $4,290 per patient per case. With an estimated 300 open surgical cases on our services, we felt that we could see at least a $1.2 million cost savings annually. So in conclusions, certainly this is a program where we have seen a significant improvement in the postoperative outcomes of our patients. Team development is crucial for the success of this program. Clear and established goals are essential to assure that there is adequate measures that are taken. The process map is definitely recommended, particularly as you begin the program. The data collection and the analysis is obviously key so that you can share the results and the success of your program. We certainly encourage research and publications. We have several manuscripts that our team is working on, so we're very, very proud of that. And then obviously it's critically important to measure compliance because, and we perhaps can draw further on this during the discussion, but one of the things that we often get asked about is, well, you have a set number of items on your criteria for guidelines, but perhaps in our hospital we cannot establish all of those. So tell me, of all of these, which one is the one that is most critical, the one that's most important. So we're actually looking and evaluating as to see which element within our enhanced recovery gives us the best outcomes and the best results. So we're looking forward to sharing that information with all of you. So with that, I think that we have the last 10 or 15 minutes to answer any questions, and I think Sean will lead the question and answer segment. Thank you very much.
Please take a moment now to enter your questions into the Ask a Question window. As a reminder, the Ask a Question window is located on the lower left-hand side of your screen. There you will see a large text box where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the Submit button. Please note that due to time constraints, our presenters may not respond to all the questions submitted.
Great. Thank you, Dr. Ramirez. That was great. I was looking through the list of questions while Dr. Ramirez was talking. It looks like we have a lot of questions actually from physicians. So that was a little different than I was expecting. Certainly my talk was geared a little more towards the patients, to be more accessible to patients. But I'll go through and answer some of the questions that I noticed that were scrolling down. The first one is whether the slide deck will be available to the webinar participants, and we were just talking about that before the web started, and I think we will have that available to you in some form, so we'll have more on that later. There's also a request for order sets, and I actually have a PDF of our order sets that I've shared with people. I can certainly email that or provide that to people who are interested. Also, you should know that the entire protocol that I described, and I didn't go into a lot of detail because Dr. Ramirez talked about that in more detail, but that protocol is published in our publication in the Green Journal in 2013. And there are also not order sets, but certainly the protocol itself is published in the guidelines that Dr. Ramirez just talked about that are published in Gynecologic Oncology, and there are preoperative, intraoperative, and postoperative guidelines. There was a question about the dose of liposomal bupivacaine. This is given in 20 cc's is the standard dose. I don't remember what the actual milligrams is, but it's 20 cc's. And it's very important to know that that needs to be diluted down to at least 180 cc's, and 220 might even be better, actually. So if you dilute it to a larger volume, that allows you to distribute it better within the wound. And this is injected above the fascia as well as subcutaneously, and we're actually working on making a video just because there is a little bit of a learning curve with injection of the liposomal bupivacaine. The other important thing is we don't use a traditional needle, but it's a blunt-tipped needle that we used after speaking with plastic surgery. So it's actually a similar needle that they use with liposuction. So it's blunt-tipped, so you can be fairly aggressive in delivering the medication within the wound. You don't have bleeding associated with that, and also injects a lot quicker. So stay tuned with a video for that. There's a question about whether the pain medications are given as needed or scheduled, and I'll let Dr. Ramirez answer that as well. But in general, the non-narcotic medications we schedule, and then the opioids we use as needed if there's continued pain despite the scheduled non-opioid medications. There's also a question about epidurals. There's just an observation that personal experience showed that epidurals were better. And again, I want to emphasize a couple things that I said, and also Dr. Ramirez said, that I don't think it's wrong to use epidurals, but you just need to understand that we've really had excellent results without epidurals. So in our cohort, on day 48 hours after surgery, 40% of our patients are not on any opioids, and that's without an epidural. And I would emphasize that euvolemia is really a critical aspect of enhanced recovery, and anything we do to potentially jeopardize euvolemia, like an epidural that can result in hypotension, I think really should be avoided. It also can potentially lead to difficulties with ambulation. And then finally, there are randomized trials that have not shown any difference between epidurals and other forms of pain control. So again, it's not wrong if you use them, but certainly if you're embarking on incorporated enhanced recovery into your practice, don't feel like you have to incorporate epidurals if that's something that you don't currently use, because that can be challenging to convince anesthesiologists to use that if they don't already. two other things, and I'm going to turn to Dr. Ramirez to answer a few questions. But there's a question about carb loading. This is included. There's a discussion of that included in the Enhanced Recovery After Surgery guidelines that are published in Gynecologic Oncology that Dr. Ramirez reviewed. There's also a question about arterial lines, how often we use arterial lines. I can't tell you a statistic. I can tell you that they're used too often, though. So we definitely use arterial lines a lot. I think most of the time we don't need them. I would love it if anesthesiology would put together sort of guidelines on when to use A lines, when to use central lines, et cetera. It would save us a lot of time and probably a lot of charges as well. Lastly, there's a question about compliance. I think there's a question about how compliance was measured. This is critically important if you're starting an enhanced recovery program. So you need to make sure that what you're doing is consistent with your order set. So if you're trying to give less fluids, you need to measure the fluids and see that you're actually giving less than you were initially. Dr. Ramirez, do you want to comment a little bit more about compliance, about how you measured compliance in your studies?
Sure, I think it's a really great question and one that we're tackling now. Our group is very actively looking into that because that's really essential. In that, you know, when we look at the data and the papers that have been published, you see that there are a number of criteria that are set as guidelines for the enhanced recovery programs. But how do we actually measure that compliance, and how good are we about measuring that compliance? I think that's where you have variables as it pertains to, you know, the adequacy of the measurements on the patients actually having a regular diet and on the initial postoperative day 0. How well are we measuring that a patient is truly ambulating 8 times a day or out of bed for 8 hours a day? So I think that these are all really critical, and particularly also when you get into the more somewhat difficult to measure elements of, you know, when we talk about total intravenous anesthesia, one of the frequent questions that comes up is, well, what is that? And when we go through the details of obviously the regimen that we explain, then the subsequent question that comes up is, well, it's 30% of the case on the total intravenous anesthesia qualify as a total intravenous anesthesia, or is 80% of the case total intravenous qualify as total intravenous anesthesia? So where do you see the actual impact is very important. So we're basically looking at all of the parameters that we set as part of our guidelines, and then we're evaluating each one to determine what level and what percentage of compliance we had with each, and we're analyzing that data now, and hopefully we'll have it for presentation at the next World Enhanced Recovery meeting. So it's a really critical question. I think one of the other questions that came up was, you know, how are you measuring patient satisfaction? And I think it's a very important question. So as we mentioned, we used the Medasi questionnaire that was developed from the symptoms research group here at Anderson. And the Medasi questionnaire is given at baseline, then is given daily while the patient is in-house, then is given on week 1, on day 3 and day 7, and then weekly all the way from week 2 all the way up to week 8. So we have a very robust amount of information as it pertains to patient-reported outcomes. One of the other questions that came up was, what is immunonutrition? So immunonutrition is a formula that is actually commercially available. There are several companies that manufacture this, but basically it's a formula that contains supplemental arginine, fatty acids, and nucleotides that presumably could potentially impact on the hospital length of stay, the postoperative complications, particularly as it pertains to infectious complications. So this is an area that we're interested in exploring. There's also another question that I see, using A-lines. We try not to use any A-lines unless it's absolutely necessary. As I mentioned, we do non-invasive cardiac monitoring. So this allows our anesthesiologists to really have a very tight control of all the information that as it pertains to intraoperative monitoring without using A-lines. There's another question as using bowel prep and what's the downside. There is significant downside because it's been shown that patient satisfaction decreases significantly and that you're going to dehydrate the patient. So therefore, if you don't need to dehydrate the patient and ideally you want to maintain adequate patient satisfaction, then why use a bowel prep when in fact it hasn't shown to be of any benefit at all in terms of decreasing your risk of postoperative complications. As I look, where can we find publications about enhanced recovery? Certainly there's going to be, I suspect, an increasing number of publications. We already have several that I mentioned in the talk. We have the guidelines in Gynecologic Oncology, and then there was another review that was also published in Gynecologic Oncology, and those are already available. But now the subsequent publications that are coming up are going to be on the actual outcomes of the results of our program, and then hopefully each of the abstracts that I mentioned will each result in publications.
And then I also see a question for me about the difference in the improvement in Exparel between patients who had a complex cytoreduction for ovarian cancer and those who had just a staging operation. So in that question, there was a little bit of misinformation about the effect of liposomal bupivacaine in patients who didn't have cancer surgery. Actually, the two cohort, and I didn't have time to talk about this in detail, but we looked at two cohorts of patients. One were patients who had ovarian cancer with a complex cytoreduction that included a colon resection or a splenectomy or liver resection, something like that. And another group of patients were those that just had lymphadenectomy or omentectomy, so a patient with a low-volume cancer or stage 4 endometrial cancer that was low volume. And certainly there was more of an improvement with the use of liposomal bupivacaine in patients that had the more complex surgery, but we still saw a significant reduction in nausea and vomiting and ileus, as well as the need for rescue IV narcotics in patients who received liposomal bupivacaine for those that had the staging only without a complex cytoreduction. So for me, and we also saw a significant reduction in the use of PCAs in those groups of patients. So for me, I use it in both groups of patients, even though it's not, the benefits are a little bit less in patients who don't have a more complex operation. And then one last question, and I'll let Dr. Ramirez talk if there's some other questions we'll have time to answer, is about urine output. So yeah, we use about 40 cc's an hour after cytoreductive surgery. This is something we have to go through every July with a new batch of patients, that we tolerate urine output down to 20 cc's an hour. That's permissive oliguria, and this is something that's perfectly acceptable. We've looked very carefully at our risk of or incidence of renal failure, and again, euvolemia is extremely important. I've said that before, but I can't emphasize how important that is for patient recovery. And Pedro, any other questions we want to answer? I see it's 12:59, so we're going to have to start wrapping it up.
I would just make a comment that there are several questions regarding how do we get order sets, or how do we establish a program. I think it's really critical to reach out to programs that have already done it, because certainly although an order set can be helpful, or a brief discussion in a webinar can be helpful, certainly that will initiate the process of getting the program started. But it's an effort that it has to be a concerted effort, a multidisciplinary team effort, so that this will be successful. Otherwise, where it's just a very scattered attempted approach, it's not gonna work. We're looking forward to actually having a seminar here at our institution to do just that, to demonstrate how to potentially implement enhanced recovery programs at your institution. So I want to thank everyone for their amazing number of questions and their input. And again, thank you, Sean, and the Foundation for Women's Cancer.
It appears that we have reached the end time for today's program. Doctors, would you like to make any closing comments before we conclude today's event?
I am available if anyone is interested in reaching out to me with specific questions or with more details with regards to starting an enhanced recovery program. Always glad to do it. This is really very impacting for your patients, and you'll definitely see a benefit. So thank you.
I think both of us are very committed to enhanced recovery, and again, I just want to thank the Foundation for Women's Cancer for sponsoring this event. This is great, and hopefully we can do more of these in the future.